This is a very intriguing point, an emerging issue in everyday practice and also in trial design. Many patients are asking for something different from radical cystectomy. At the time they realize they have achieved a complete response, clinically evaluated with the radiological examination, I don't know, CT scan or MRI. So at that point it's important for us to be able to provide them with an answer. And the trials are ongoing today, mainly United States today, that are aimed to provide patients with a bladder sparing strategy, provided that they have achieved some kind of complete response after neoadjuvant therapy. Regarding biomarkers, we do have some initial data supporting, for example, the potential association of DNA damage repair gene alteration and the efficacy of neoadjuvant chemotherapy. This may be same for immune therapy. The same alteration may also provide some benefit with neoadjuvant immune therapy. High TMB may provide an additional benefit, but it is still something that it's a story that is still to be built. Another very important and promising biomarker to use is ctDNA, circulating tumor DNA, and the patients who achieve a clearance of the ctDNA after the induction phase may have a reliable opportunity to spare the bladder. Finally, clinical complete response as a biomarker for allowing patients to save their bladder. But of course, we still need to find harmonization and the right definition of a shared definition of clinical complete response in these patients.